And welcome back. I'm Mabel, Jong. You're watching continuing coverage of the World Healthcare Congress in Washington, D.C. A special welcome to those of you joining us online. In our studio right now is Dr. Joe Gifford, Senior Vice President of Provider Markets for Lumeris. And Dr. Gifford is based in Seattle. How are you today?
I'm very well, thank you.
Good.
Beautiful day here.
Yes, and you'll be doing a panel in a little bit. Tell me what the topic will be.
The topic is value-based contracting, how to create good value-based contracts between payers and providers.
And how do you do that?
Well, that's really what we're all about. So we at Lumeris provide services and technology to help value-based contracts both for payers and providers. So that's really the most important dance there is getting payers and providers together. We often work as matchmakers, actually, because we have provider customers and payer customers. We're in a regular rhythm of helping payers look for collaborative providers that will make good partners. And when we're working with a provider system, we're looking for the collaborative payer that will make a good partner.
Okay.
We pretty strongly believe that the old school of products, healthcare products, broad PPO products, or we call them free-range PPO products, where a beneficiary can shop anywhere around the state and sort of make up their own network. But those products are actually bad for your health. We think they're actually, a lot of data shows that free-range products really give poor quality scores, and even their one study gave even worse mortality scores, actual health of seniors who are in PPO fee-for-service products. Mm-hmm. So we think it matters. We think how you pay for healthcare matters. We think how you structure arrangements between providers and payers really matters in health outcomes as well as financial and quality outcomes.
Mm-hmm. And when you talk about free-range products, what are you referring to?
The old school of a PPO product in which you as a beneficiary, well, Medicare, traditional Medicare is a free-range product. Most sort of traditional blue contracts or the national payers, they let you go anywhere. There's no constraint on seeing a specialist or seeing a specialist here and picking another specialist on the other side of town, going to an emergency room here, going to a primary care doc over there. You can kind of pick your own care by your own choice. Mm-hmm. And so we call those free-range products.
And so your data is showing that that's actually been very poor for people's health?
Yeah, so it's not our data, but it's published. There are published studies out there. There's an example in the American Journal of Managed Care in which they compared two cohorts of patients in Medicare Advantage in Portland, in which one cohort was managed by a group that was paid pure fee-for-service, and another cohort was managed by a group that was capitated, purely capitated. And you would expect there would be fewer hospitalizations and emergency room events in the capitated group, that they would be more engaged. Which was true. But what was really surprising is they did the survival curves of the seniors, and there was no question there was a 35% survival advantage in the seniors who were cared for by the capitated physicians who were at risk for outcomes. That was a clear result, that having the fee-for-service payment method in that study actually was bad for people's health.
Right.
And there are many other studies that show that the health and outcomes, quality outcomes, are better in Medicare Advantage in general than they are in traditional Medicare. There are studies that show that HMO product design is better than PPO product design for quality outcomes. There's lots of data on that. We think the fee-for-service, we think it's almost administrative malpractice to structure the payment for healthcare as fee-for-service for widgets that you can go get on your own anywhere in town with nobody really coordinating them well. We think that's just the wrong way to pay for healthcare.
So what is Lumeris's approach? How do you work to fit people together, to matchmake?
What we do is, we do really two major things. We start Medicare Advantage plans for providers or a combination of providers and payers. We also create population health service organizations that are mostly provider focused, that pull in multiple payers into a provider system and often can have multiple payers, multiple providers as well. So we become partners with a system. And those partnerships will allow us to get deep within the provider system and work with them on how they're contracting. We find that if primary care doctors have a little bit of business that's at risk or that's value-based, they don't really pay attention to the behavior changes required. So we strongly encourage all our customers to create value-based contracts with multiple payers so that they have a density of risk-based contracts in their panel.
And so what's the message you're going to be leaving when you participate in the panel later on?
I think so. The message is, first of all, that creating value-based contracts is super important for healthcare, but that the actual way to do it on both the provider side and the payer side is to have a deep partnership. That it's not just a matter of putting out some outcomes, some pay-for-performance outcomes that you give $1 to PMPM for. It's a matter of a deep partnership in which both sides are committed, where the payer is deeply involved in the provider's business, where benefits change so that the providers are supported in their efforts to give primary care that stays within some coordinated system. That data is shared freely, that payers usually have the data, they have the claim data, but they also have analytic data. They have predictive models, they have episode treatment groups, they have financial data, they have PMPMs. The payer has a lot of data, has to be freely shared with the providers so the providers can see what they're doing. And on the other side of the equation, the providers have to be right in there working to make the plan succeed. They have to be able to do all the preventive care that's required. They have to report back to the payer. So a true payer-provider collaboration is a deep partnership. It's like a marriage, and we encourage both sides to get in there and really work on it.
All right, Dr. Gifford, thank you so much for your time today. I really appreciate it.
Thank you, Mabel. It's good to meet you.
And I'm Mabel Jong. Thank you for watching. Stay tuned.